We're talking to providers about how do they go about making sure that their documentation now gets beefed up and comes up to par so they can bill properly and pass audits that you folks, because one of the things that you're doing for your Medicare risk folks is collecting information on their chronic conditions. And so we want to make sure the doctors are documenting properly, not just billing you the new codes, but making sure that their clinical information matches it. So we're telling them they don't need to hire a consultant or anybody else to do this. They can do it themselves. And they just run a list of their top ICD-10 codes, whatever they billed in 2013, run a list of the top 20, identify those patients and pull out those charts and just see, does it say sprained wrist? Because it needs to start saying sprain of the carpal joint of the right wrist. So just pull it and then give the doctors feedback on that. Let the doctors know that, okay, you said asthma. Asthma right now, generic, unspecified asthma, ICD-9 493.90. In ICD-10, it does not, there is an unspecified, but it doesn't exist as a one-to-one crosswalk. Mild asthma, moderate asthma, severe asthma, intermittent, persistent, there's a whole lot of other criteria for asthma. And it's clinical criteria. It's not like we're telling the doctors you have to start saying these words so you can bill Aloha Care. It's like you probably already know if your patient has mild asthma that's persistent or severe asthma where they're on their inhalers 3 times a day. You know that. And if you do, then that's what you should start documenting so it can be billed correctly in ICD-10. We're comparing the documentation, making sure that whatever they're documenting can support the increased specificity. And then feedback. This is all we hear from the doctors is, okay, I get it. I get that this is going to happen. If I'm not doing it right, tell me what to do and I'll do it. They just need a roadmap. And so that's kind of what we're doing, is giving them some cheat sheets. Okay, so we've talked about mapping. So the General Equivalence Mapping System, or GEMS, is something that was created by the government. 2 versions of it, one on the for payers and one for providers. And basically the only difference is the payers will often want to backwards map, and I'll explain that in just a moment. And the providers are just saying, just tell me what ICD-10 code is equivalent to this ICD-9 code. But a general equivalence mapping system, all it is a mapping tool created by the government, and it's free. You could download it if you wanted to from CMS. It's an ugly looking file. It looks like the old DOS files, you know, those ugly black screen files with just 10 million numbers in there. But a lot of vendors have just taken that ugly file and made it pretty, Windows based and colored and added features and whatnot. And that's really all we've done with our product, and that's every product I've ever seen, that's all they've done, is taken the GEMS file and spiffy it up a little bit. We're using it as a training tool, again, for those documentation elements, and I'm going to show you what that looks like. And the mapping identifies a one-to-one map and a one-to-many map. Only about 5% of all of the ICD-9 codes map directly to an ICD-10. Only about 5%. Many of them you'll have some you'll have one-to-one. 1 to 2, 1 to 3, right? Left, right, bilateral. That's now 3 codes. There's a lot of them that map 1 to 20, 1 to 25, so you won't have that exact crosswalk. Okay, whatever product you get, if you're searching for something to use within Aloha Care, if you're asking your vendors, your software vendors, what they can provide in the way of an interface, make sure that it can search by both the code number and the description. The AAPC, our parent coding organization, has a free one on our website, which is really good, except you have to know the number of the ICD-9 code. So if you don't remember the number, you can't punch in the description of it. So make sure that you have one where you can put in words or numbers. For you folks, it's really important that it's bi-directional. Almost everyone I've ever seen can go either way, but you want to make sure you can map from I-9 to 10, or if you get a claim tomorrow with a 10 on it, can you backwards map it to 9 to figure out what that is? So make sure it's bi-directional. You want to make sure that it can perform the search and record it, save it. Cheat sheets, favorites list, whatever you want to call it, because once the nurses, let's say you're getting a request today for I don't know, pre-authorization for a radical mastectomy, breast cancer, 174.9, put that in. That's going to map to a whole bunch of different, because guess what? Left, right, bilateral, right? So you've got at least 3. In fact, a whole lot more for breast cancer, because it's now specific to where in the breast. Central portion, inner portion, outer portion, and so on and so on. Male and female, different codes for breast cancer for male and female. So anyway, you're gonna, once you look it up and you map it, you wanna be able to save it, so you're not looking it up every single day for the next 8 months, or not every day, but often enough. So make sure you have the ability to save it. Print function is great, so you can print out your favorites list or the information you're looking up and start creating a little booklet or something that you may want to, you know, wallpaper your walls with it or something. But print function is great. Most of them that I've seen are a standalone product, so it resides on a laptop. It certainly could reside on your desktop. It's just a standalone. It's a the one that we use is a web-based version. So if you have, let's say, 5 licenses, I mean, all of you could use it because it's web-based. I don't think everybody could be on it at the same time. I don't know really how that works, but probably not. But it's web-based, and so it's something where any workstation where you happen to be, including your phone or your iPad, you could, if you really wanted to search for ICD-10 codes on your iPhone, I guess you could. But certainly the iPads, you could use a tool like that. So here's what it looks like when you map a code. So for instance, osteoarthrosis. So osteoarthritis as we know it of the knee. So osteoarthrosis localized, not specific as to whether primary or secondary. ICD-9, we don't even have a code for knee, if you can believe that. We have to use lower leg. That's the problem with ICD-9. Anyway, osteoarthrosis localized, doesn't say whether it's primary or secondary, lower leg, 715.36. That's a popular code. This one too, osteoarthrosis unspecified, generalized or localized, lower leg. So one of these two are the ones that folks use most of the time for osteoarthritis of the knee. So let's say they're authorizing a procedure, they're authorizing a knee replacement, they're authorizing even just an MRI, whatever it happens to be. When you plug this code, this diagnosis code in, because remember, unspecified, ICD-9, that's what it is. It's a mostly unspecified file. When you put it in, you're going to get, guess what? Osteoarthritis of the knee, unspecified. Junk in, junk out. Unspecified will cross to an unspecified. If you want to start collecting more accurate data, and I don't know why you wouldn't, here's what we've done in our GEMS file. All of them can do this. Any GEMS file will map it. And for those techies, if there's techies here, you know all about this approximate no map combination scenario. Those are all fields within the GEMS file that mean something. I have no clue. All I care about is it maps to something. But we've added these additional options. So when we do this crosswalk, it comes up on your screen where it will show unspecified comes out, unspecified comes out to unspecified, unspecified comes out to unspecified. However, if you wanted it to be bilateral primary osteoarthritis, unilateral primary osteoarthritis of the right knee, it gives you that choice there. So this, I don't know how much help and feedback you'll be giving to your providers, but if a claim comes in like this and you say, okay, was that the left knee or the right knee? Offering them that solution that you now have options for left, right. In this category, you do not have a bilateral, so you code the left and the right if they have both. Some categories have the bilateral. So many of the sections when you do the mapping will give you the other options that are more specific. This is what we're using for the doctors, for the clinical documentation improvement, as we're saying, sure, you can try it. Go ahead and send that to Aloha Care, and maybe it'll get paid. Osteoarthritis of the knee, unspecified. My guess is you're going to be saying, well, they probably know if it's the left knee or the right knee or both knees. So we tell the docs, could it be one of these? Because if it is unilateral primary osteoarthritis of the left, then let's bill it that way. Let's bill it correctly, but we show them the verbiage. We show them what they need to be saying that is different. So how might you use a lookup of some type, a crosswalk of some type? Obviously, it's a quick lookup, and I'm going to show you that next. I'll show you how the program actually works. But it's a quick lookup for the commonly used codes. Performance measures. If you are collecting any information for performance measures, and I'm sure you are, for your Medicare folks as well as maybe others, providing a guidance. I can tell you right now, if they haven't started asking you yet, they will, because if they are being asked to perform certain quality measures, and it's tied to an ICD-10 code, they're going to ask you for that list. They don't want to look it up themselves. They figure if they're having to report to you, I don't know, smoking cessation counseling because the patient's a 20-year, 2-pack-a-day smoker, how do they code that? They're going to ask you, because that's what they're telling me. Contract renewals, that's the other thing. If you have any services that you pay for or you don't pay for, not as important for you folks because of the Medicaid side and the Medicare side, but on the commercial side for this, if there is any CPT code that is covered or not covered for a particular diagnosis code, all that has to be changed. And we're telling the doctors to go back and look at their contracts. So if skin tags is never payable because it's cosmetic, there's one code in ICD-9. There's 8 codes in ICD-10, including bleeding, irritated, something and something. Are you now going to cover that for bleeding skin tags? So you're going to be getting those questions from the providers as to, okay, we never used to get paid for this, but now we have a better code that really describes it. Can we get paid? I don't know policy-wise, but it's something to be thinking about. Pre-authorizations, anybody who's on the receiving end of those pre-auths, the lookup is going to be your new best friend. Utilization review, same thing. Customer service, folks on the phone even. Why would they need ICD-10 training? Well, they have to know enough about it to know when a provider calls and says, I can't understand why I'm getting this rejection. I thought I billed it right. I used the mapping system at Crosswalk to this. Unspecified knee. Why am I not getting paid? Now that customer service person might not be advising as to why that claim was paid or not, but maybe they are. They need a quick lookup, some way to backwards map or forwards map based on maybe your internal policy for payment. Here's a favorites list, an example of the favorites list. This is from our product, but you should be able to do this in almost any. So if you're getting a request for, let's say some sort of, I don't know, ultrasound of the abdomen for pancreatitis. In ICD-9, you have 2 choices, acute and chronic. In ICD-10, you've got 1, 2, 3, 4, 5, 6 choices. So when you put this into the system, and I'm going to show you how it works, you put in pancreatitis, ICD-9, it'll bring up your 2 codes. Save it. Switch it to ICD-10, you map it, it brings up your 6, and you save it. Whichever one it is, it doesn't matter, because now you've got this memorized in a document. You don't have to look it up again, and you can start building this and building and building and building. Osteoarthrosis, 715.16, 26, 36, 96. Any one of these, put those in your ICD-9, map it, you come out with your 10. You don't have to look it up again, it's now saved. Effusion of the joint, lower leg, which is knee, 3 choices, right, left, unspecified. Once you put it in, you look it up, you map it, and you save it. So this is how you start familiarizing yourself with the codes, especially the ones where you're always doing pre-auths. Anything that you require pre-auths for all the time, I would start there. So you look it up, save it, look it up, save it, and then that part of your work is done. None of these codes will change, by the way, in ICD-10 because of the code freeze. These codes are good until October 1st of 2015. So don't worry about building your list too soon that it's going to change, because it won't. When we talk to the clinics, the health centers, we remind them that productivity is going to slow down on their end. Remember that whole alphanumeric thing on the keyboard, that's going to slow things down. Looking up whether they're using a book or their EHR, wherever they're looking up codes, it's going to take longer to find it, at least until they get used to it. The GEMS file shouldn't be the only thing that they use. They need to really understand a little bit more than just mapping. So it shouldn't be the only requirement. And of course, the unspecified ICD-9 is going to map to an unspecified ICD-10, so that may be acceptable at first. Here's just another example. Eye pain, which is called visual discomfort in ICD-9. It unspecified maps to an unspecified. When you run this through our system, you get the left, the right, the bilateral, as opposed to the, if in fact the bilateral exists. Sometimes in the eye things, if there's no bilateral, then again you would use a code for left eye and right eye as well. So that's just another example of a report. Here's another one. This just shows you that follow-up, as I just mentioned, the right eye, the left eye, the bilateral eye. This particular section for the visual discomfort does have the bilateral, but you could see from previous, ICD-9 was so unspecific that when you plug it in, a lot of times you're going to get that. So you want to be able to, a lot of these you would know that if it's, like I said, anything you have 2 of, you're probably going to have at least 3 codes. Just remember that. But the providers will want to have some way of knowing and finding easily that they've got the choices. Okay, we talked about the authorizations and the eligibility, more granularity, of course, the fact that the codes are so specific. I mentioned that the coders now need to really start brushing up on their anatomy and their terminology, because you can see already that some of these terms are not terms that we're used to seeing. It's eventually going to get more streamlined, but that's going to be a while before we get there. Is Aloha Care going to approve and adjudicate your services using I-9 or 10? I mentioned that previously, that if and this isn't certainly just Aloha Care, but if a plan is not prepared for, or not able to, or chooses not to upgrade to the 70,000 ICD-10 codes, there are some plans that are saying, okay, well, you go ahead and send us your ICD-10 code. We're going to internally backwards map it to an ICD-9, look at our policy for payment, and pay it. The provider will never know the difference, right? Because they got paid. They're just happy they got paid. But internally, if you're not ready, you're not prepared to handle all of the codes that require a secondary code, if you're not prepared for all of the 16 different multiples of fracture codes with various healing stages, if you're not ready for that, you can accept that ICD-10, who cares what it is, because you're going to take that code, backwards map it in your mapping system. It'll give you the equivalent ICD-9, which is probably unspecified. No harm done, because that's what you're paying right now. So it's just a transparent process to the provider, but it's just something, the same thing for adjudication. If someone is either approving or not approving, if you're not fully prepared system-wise to accept the whole entire 70,000 file, accept what you've got, backwards map it, pay it or not, and provider never knows the difference. So it's just another option, and there are a number of plans that are looking at that, simply because they plan to be ready, but aren't really sure if they will be ready. Appeals, reconsiderations, treatments, anything that's occurring pre-transition time, those are going to have to be crosswalked. And here's an example of that. This is the one that sent Stella into a tailspin when I was here in December. So skilled nursing patient, seeing the physiatrist, pre-authorization for long-term care ICD-9 coding. So let's say this is a patient that had a fractured hip. If it's a closed fracture hip, you're looking right now at 820.01. If it's a patient's in this long-term care situation because of a non-union, non-healing of this fracture, you're probably looking at this code, but you only got one, either way, you got one choice in ICD-9. In ICD-10 now, from a pre-authorization or a payment adjudication perspective, here's what you're looking at. Displaced fracture, epiphysis, right femur, subsequent encounter, closed fracture with non-union. Here's the K extender. You asked about the letters. In this case, a subsequent encounter, which should have been a D, right, under, normal A, D, and S. It's a subsequent encounter, but because it's specific to the non-union of the fracture, it's a K. So the point here being, this burden will A, be on the provider up front, or it's going to wind up on you guys, right? To pre-authorize. So this patient now in August gets pre-authorized for rehab using this. That claim is now going to come in with this, we hope, or some reasonable facsimile thereof. The providers are saying, how am I going to know that? And all I can say is, well, in the patient's electronic medical record or in their medical record, would you not know this? And they're saying, no, all we know is it was a fractured hip that's not healing, which sounds a little weird to me, that they would not have this in the patient's clinical history from the orthopedist that treated them, but I'm hearing from the docs that they won't ever be able to get this drill down information. So I don't know what's going to happen. Someone must know that if the patient's being treated for it. But my point being, for you folks, you're now going to get this. You can take that, try it, backwards map it, and see if you come out with that. You should. Or something close to that. And that's what I meant about the reverse mapping process. Because if you get that, you can look it up in the lookup and say, okay, well, great, that's a displaced fracture epiphysis, and that's what they told us the patient had, so we're going to authorize this now, and we'll pay. That's great, but you may or may not get that accuracy in the code. So that's what I meant about preparing yourselves now for the increased workload, for the learning curve of this, and being able to practice with some of these. You know how many of these you've pre-authorized in the last 2 months, or take any code and just start mapping them and see what happens. Here's an example. The nurse knows that she has pre-authorized 820.01, and now we're redoing it. Map it. Here's the choices. Epiphysis, upper right femur, initial encounter closed, same thing, subsequent encounter closed, and these are all, I cut it off over here, these are all, excuse me, various stages of healing. But you've only got 6 choices. And that would give the nurse or the person who's reviewing it the opportunity to go back then to the requesting physician and say, how's that healing coming along? Where are we with that? Is it a malunion? Is it a non-union? So it gives you the ability now to request more information to tell you where that patient is and how they're getting along, how they're improving or not improving. In the end, this is going to be really good, right? Because we'll have terrific data. However, for the next few months, I don't want to say years, for a while, it's getting there that's going to be a headache. Okay, one last thing, workers' comp and auto. Right now, workers' comp and auto, it's all state specific. It's not federally mandated. They do not fall under HIPAA, so they do not need to change to ICD-10. So there has been some discussion on the legislative level to require automobile and work comp payers in Hawaii to use ICD-10. The legislature's only so long, and unless somebody's doing something right now, that probably won't happen. So there's been some discussion about whether or not the insurance commissioner can make them do it. I don't know how that works. I'm not holding my breath. I just know I spoke to a friend of mine who works at one of the larger bill review companies here that does work comp and auto. That's all they do. And she said they will accept either ICD-9 or ICD-10 codes, but they're going to have to internally map it. That technically they don't have to accept 10s, but they're being proactive because they know that most of what they'll get is a 10. I mean, after October 1st. So they want to be ready for it. But the problem with these is when the patient shows up in the Queen's emergency room in the middle of the night with a car accident and maxes out their insurance policy in 5 minutes, then it gets billed to auto, it gets denied, it comes back, and now it will be billed to their alternative insurance, because MedQuest is payer of last, right?
Yeah.
Yes. So now that claim's going to come to you. Well, it's been coded in 10, no, it's been coded in 9, ICD-9, because it went to auto. Now it goes back to the provider, who recodes it in 10 and sends it to you. Or do they just send it to you with the ICD-9 code? That's why you want a product that can backwards map and forwards map. This is going to be a real headache in the doctor's office, in the clinics, because now they need to go back to the doctor and say, can you recode this now in ICD-10, because we have to submit to Alomacare. Work comp, the other way around, right? Patient shows three months after they get injured, they say, did I forget to tell you that I hurt my neck at work? So now they've billed Alomacare for all those claims using ICD-10, and they've got to undo all of that and now bill work comp. So on the provider side, this is really going to be a headache. So I'm hoping that eventually work comp and auto will jump on the bandwagon. It's state specific, and there are a couple of states that have already required, like New Jersey I think is one of them, and someplace else, that have said you must use work comp and auto, you must use I-10. So I guess the state has the ability to do that if they want to, or if they feel it's necessary. But those of you that have been around for a while, do you remember how long it was when we switched to the E&M codes? The work comp and auto were still using the old 90060 and the 90050, those old office visit codes for years. I mean, years until they switched to the E&Ms. And everybody else, it was just awful. But anyway, so we don't know. They don't have to, but we're hoping that they do. Okay, so we're already getting started. We're already doing that. We've started the code set training. That's part of what this is. Specialty specific training is something we're doing for the providers starting in March, along about March. So whether it's OBGYN or orthopedics or neurosurgery, we're doing general training, which is really awareness and not specific to their specialty, because we don't want to teach it too soon and have to have them relearn it again, because we'll never hear the end of that they learned it and forgot it and had to relearn it. So we're telling the providers that we would like to see them parallel coding no later than summer. Not 100% of their work, but a small percentage of their work. So if a nurse is filling out a lab slip, she fills it out with her ICD-9 codes, and just do another one and do it in ICD-10. If you fill out 5 a day, just do 1 or 2, just so they get in the habit of doing it, and their questions come up long before October 1st. Billers, we're telling the billers, if you do 100 claims today, just do 10 of those using both code sets. And then they're going to be wanting to submit test files. I don't know whether you folks are prepared to accept test files as of yet. I've heard that HMSA, I think, is sometime, I want to say it's April, I think is when they've said that they might be ready. Other payers have said they can send them the claim forms with the codes, and they'll run it through and see if that works. But most folks want to send an electronic file and make sure that that flies. So if you're not ready for it yet, you will certainly be getting some questions about that, because they're learning the codes. Pretty much their systems aren't ready. The clinics system, the health center systems aren't really ready to be able to submit a file, so you've got a little breathing room. But that will happen, I'm sure, by summer at the latest. One thing you can start doing, I think you've already started doing this, is looking at the workflow impact. You can start doing that internally. So everybody that touches an ICD-9 code right now, figure out what they do, what level of training they need on ICD-10. Update your resources. As I said, you can buy your books now. You can get your encoders now. They're not going to change. The codes won't change until 2015. So you got plenty of time. You won't have to buy it and then buy it again. Put together your training timeline. Again, folks within the organization need different levels of training. So figure that out and say, well, who needs what? And then maybe put together small groups just for your nurses, or small groups for claims, and go over the specific training. and then take a look at the transition software. So as promised, after all the gloom and doom and the bad news, I'm here to tell you, isn't ICD-10 wonderful? Hopefully, the more specific diagnoses, you'll have less in the way of requesting notes, you'll have less in the way of denials, because they have a better way to report to you what's being performed. I'm hoping anyway. Higher diagnostic complexity may support some of those procedures. So if you get a claim request for a PET scan on a patient and the diagnosis is unspecified colon cancer, you may want something more specific than that. Where is that colon cancer in that stage, and do you pay for PET scans, for unspecified type colon? Don't you want to know the progression of that patient's disease process? Better data, it's all about better data. As the providers are now starting to join with the patient-centered medical home models, the accountable care organization models, that's really the latest wave for providers, and it's diagnosis-based reimbursement. So right now, they get paid for a 99214 if their patient has pharyngitis. They might get paid a 99214 if that patient has pharyngitis and COPD and acute asthma exacerbation and diabetes and Alzheimer's disease. Same payment, right? That fair? Sicker patient requires more resources, so that now the doctors are looking at accountable care organizations where it's diagnosis driven. The sicker that patient is, the more money they get for that patient, for taking care of that patient, and not necessarily just fee-for-service office visits. So these are really popping up with some of the other plans now. CMS is big on this accountable care because they want to know how sick these patients are. They want all that data, and they're willing to pay plans such as yourselves if you collect that chronic disease information and you report it to CMS. They're willing to give you money for that, and in theory that money trickles down to the providers if they give you that correct data. But right now, I can tell you right now, what you get on your COPD is 496 and diabetes is 250.00, and they might have chronic kidney disease, 585, but they're not using the correct diabetes with kidney disease manifestation, so your data is junk. So eventually the data will be really good, and you'll be able to fulfill your responsibilities to CMS as a plan, but you're reliant, of course, on the doctors, but now they have a way to, bill it better, to report it to you better. And again, same old stuff, tracking, reporting, better describing new diseases, same old stuff, but really it's all about collecting the accurate information. I gave a talk for one of the health plans that participates in Medicare Advantage, and it was all about the chronic disease burden management, explaining diabetes and chronic kidney disease and how that should be reported. And one of the doctors said, it's great to be able to report the information, but in the long run, if we don't report it, that health plan might go away. If they don't have enough information, they don't have enough members, they can't get the money, that plan goes away, and then the patients suffer with not having choices for plans. And I thought, well, that's a different way of looking at it, but it's very true, that we want to collect the information so you guys continue to thrive and flourish and provide that valuable service.